Hello, my name is Kavita. I'm one of the endocrine registrar. I want to present today regarding a paper called Impact of Routine Clinical Measurement of Serum C-peptide in people with a clinician diagnosis of type 1 diabetes. This paper was published in October 2020, and it was a study done in Edinburgh. So establishing the correct cause of diabetes is important because different forms may be managed in different ways, and incorrect diagnosis can result in years of unnecessary insulin therapy. Traditionally, clinicians have used clinical criteria to establish the cause of diabetes, including age of diagnosis, ethnicity, BMI, and presence or absence of ketosis. It is recognized that these clinical criteria can be imprecise and misclassification can occur. Moreover, islet cell antibodies such as glutamic acid decarboxylase GAD antibodies, islet cell antigen autoantibody IA2, and zinc transporter 8 may not be present in diagnosis in people with type 1 diabetes, while false positive antibody test results can occur, especially if only a single antibody is measured at a low titer. Therefore, recent attention has been focused on the use of biomarkers such as C-peptide to improve the diagnostic accuracy of classifying diabetes. So C-peptide is a component of proinsulin and provides a measure of endogenous insulin production. Individuals with low concentration of C-peptide will have a deficiency of endogenous insulin, and this is usually consistent with a diagnosis of type 1 diabetes. Substantial C-peptide secretion is consistent with an insulin-resistant state, and a diagnosis of type 2 diabetes can be made, although some individuals with type 2 diabetes can also have a degree of insulin deficiency. C-peptide is most discriminatory when used in people with diabetes of 3 years or more than 3 years duration.
Is it either type 1 or type 2?
Both.
Yeah.
So basically, in patients who are type 2, and if they've come in with diabetic emergencies, there can be glucose toxicity, which can cause a falsely lowered C-peptide, and hence it should be measured after 3 years duration. And if they're type 1 diabetic and they've just come in, then they could be in honeymoon period, which can actually last up to 7 years. So hence 3 years duration is the recommended time to check.
Okay, that's a long honeymoon, 7 years. Okay.
Okay, so aim of the study and objectives. The aim of the study was to determine the impact of the routine use of C-peptide in an outpatient clinical setting on individuals with a clinician diagnosis of type 1 diabetes. So in this single center study, individuals with type 1 diabetes of at least 3 years duration were offered random C-peptide measurement, and it's a serum C-peptide at routine clinic review. A C-peptide of more than 200 picomoles per liter were prompted further evaluation of the individual using a diagnostic algorithm that included measurement of islet cell antibodies and genetic testing, if not already done. Where appropriate, a trial of anti-diabetic co-therapies were considered. So for the participants, C-peptide was introduced as routine clinical service development at Diabetes Clinic at Western General Hospital, Edinburgh in July 2017. Over 24-month period, 953 individuals with a clinician diagnosis of type 1 diabetes and had a diagnosis of more than 3 years of diabetes were eligible for measurement of the serum C-peptide. Diagnosis of type 1 diabetes was made on the basis of routine clinical information available around the time of diagnosis. And all of these individuals are on insulin therapy. C-peptide was tested in 889 individuals, which were 90% of the eligible cohort. It was not undertaken in 94 eligible individuals for a variety of reasons, but primarily because they did not attend clinic during the testing timeframe, or the clinic doctor did not remember to take a sample.
Yes.
So for serum C-peptide measurement, it was measured during a routine outpatient clinic appointment on a non-fasting random sample using Abbott Architect C-peptide immunoassay on an Abbott Architect I2000 SR analyzer. Blood glucose was measured as well to ensure no reduction in beta cell stimulation by hypoglycemia. Repeat samples were taken on a different day if blood glucose was less than 4 at initial testing, and C-peptide data was reported in picomoles per liter. So for Islet autoantibody measurement, the antibody testing was not performed as a matter of routine at diagnosis, especially prior to 2005. So where antibody testing was performed, it usually typically included GAD antibody either alone or in combination with IA2 antibodies. Where antibody results were not available or were insufficient to make a diagnosis of type 1 diabetes, additional antibody testing was undertaken. Antibodies against GAD, IA2, and zinc transporter 8 were measured using the RSI ELISA assays done by the Department of Immunology at Royal Infirmary of Edinburgh. For the cutoff for C-peptides, so the C-peptide cutoff were based on data from Exeter using the Roche serum sample C-peptide assay. In Exeter studies, C-peptide of less than 200 were considered indicative of severe insulin deficiency in keeping with type 1 diabetes or other insulin deficiency states, such as diabetes secondary to pancreatitis. In a comparison study, the study found a highly predictable relationship between the Abbott and Roche assays. So for the purpose of this study, we were using Abbott assay C-peptide of lesser than 200 as the cutoff to be indicative of severe insulin deficiency. So for the cutoff, C-peptide of more than 600 was regarded as evidence of preserved endogenous insulin secretion, while a C-peptide of 900 was regarded as evidence of significant insulin resistance consistent with type 2 diabetes or another insulin resistant state. So individuals with C-peptide less than 200 were considered to have severe insulin deficiency, and they were consistent with a diagnosis of type 1 diabetes or other insulin deficiency state, and they were not evaluated further. But if they had a C-peptide over 900, they were considered to have type 2 diabetes and were not investigated further. However, if they had C-peptide between 200 to 900, they had further workup to determine underlying cause of diabetes as per algorithm, as they can be type 1, type 2, or even MODY. Obviously, this algorithm presumed that any potential causes of secondary diabetes, such as chronic pancreatitis, has been considered and has been excluded. So this is the algorithm used. For patients, like I mentioned, so anyone who has a C-peptide with less than 200, they were considered to have severe insulin deficiency and deemed as type 1 diabetes. No further investigation needed. If they've got a C-peptide over 900, they were considered to have significant insulin resistance, and they were deemed as type 2 diabetes. If they have a C-peptide over 200 to 900, they have a significant endogenous insulin secretion. They can be type 1, type 2, monogenic, or MODY, and we would do antibody testing on these patients. So once the antibody testing is done, if they have one antibody strongly positive or more than one weakly positive, they were classified as type 1 diabetes. If they have one antibody that is weakly positive, they would go into this algorithm, which would mean that they would be tested using type 1 diabetes genetic risk score. This is a novel tool which can help differentiate monogenic diabetes from type 1 and type 2 diabetes. And it's a new pathway to identify individuals in whom clinical features as well as autoimmune markers are equivocal. So this is a DNA test, a genetic test, where they do sequencing analysis of 10 common genetic variations that are associated with type 1 diabetes. So if the type 1 diabetes genetic risk score says that this patient has high probability of type 1 diabetes, they would then deem to have type 1 diabetes. If they were deemed not to have type 1 diabetes, then they would be tested for MODY by next generation sequencing that was done at Dundee. If they were tested positive, then they were reclassified as MODY. And if they were negative, then they were classified as type 2 diabetes. Now, for patients with C-peptide between 200 to 600 or 600 to 900, so these groups, in the absence of raised BMI, they would enter this pathway, which they underwent monogenic diabetes testing for MODY, and if negative, they then went on to have a type 1 genetic risk scoring, and then reclassified as type 1 or type 2, depending on the results of the type 1 diabetes genetic risk score. If the monogenic diabetes screen were negative, final classification was also based on clinical judgment, and they could do diabetes prediction model from Exeter, which is a calculator online. Insulin cessation were considered for a group of patients who had C-peptide over 600 or had sulfonylurea sensitive form of monogenic diabetes. The choice of co-therapies were left to the discretion of clinicians, but for individuals reclassified as type 2 with a C-peptide of more than 600 were generally started on metformin, SGLT2, and GLP-1 analog in stepwise sequence. Addition of co-therapies were considered for some individuals that were reclassified as type 2 with a C-peptide between 200 to 599, particularly adding in a sulfonylurea. The reason why this study is done, because cost implication analysis used insulin cost based on NICE, and in August 2015, NICE has estimated the annual cost of insulin therapy for an individual with type 1 diabetes using multiple injection therapy to be £890 per annum. And this included insulin, injection, and blood testing consumables. The annual cost of an individual with type 1 diabetes using an insulin pump was £2,700 per year. The annual NHS cost of glycoside 80 milligrams daily was approximately only £12. C-peptide assay was £6 per sample, and triple antibody testing was approximately £32 per sample. Monogenic diabetes testing was £250 per sample, and the type 1 genetic risk score was £60 per sample.
None of it sounds that expensive. I mean, a pump and insulin is not.
It's good value.
It's good value.
Mm.
It's all good value.
Years ago, when they looked at glycoside, but I noticed that they went directly, and I would agree with this, to Flozins and GLP-1s.
So from the 859 participants, 754 participants had C-peptide less than 200, so 86.8% were deemed as type 1 diabetes. 114 participants, which are 13%, had C-peptide over 200 and then entered the investigation pathway. So, okay, 54 participants met the diagnosis criteria for type 1 diabetes after entering the diagnosis pathway, and 58 participants were reclassified, with 44 being reclassified as type 2 and 14 reclassified as monogenic diabetes.
So that's 6.8% of the total cohort.
That's
Yes.
quite interesting, isn't it? In a type 1 clinic,
out of 859.
it's 58 out of 859, yeah. Okay.
Oh, yes. Yes.
So individuals with C-peptide more than 200 were older at diagnosis than those with C-peptide less than 200. And only 9 patients from the 364 of individuals aged under 18 at diagnosis had a C-peptide over 200. So age is an important factor regarding C-peptide.
Nine young people were labeled type 1. Isn't that interesting? That's quite, I think it's quite a lot. I know it's a small number.
Had more than 200.
So those 9, they were young. So you see they're type 1 diabetes, I see that.
But we think they might be amazing.
Well, I don't know. Could you tell us? Sorry, Kavita.
So for the type of the 114 individuals with C-peptide over 200, 54 met the diagnosis of type 1 diabetes. And as you can see from graph here, some had C-peptide up to 900. So it's very variable. Most individuals had C-peptide from 200 to 599, but nine of the patients had C-peptide between 600 to 900, despite being type 1. And the median duration of diabetes for these 9 individuals who had a high C-peptide was they had diabetes for 6 years, with the median age and diagnosis of 41 years. No patients that had a C-peptide over 900 had a positive antibodies. And as for type 2 diabetes, median C-peptide was around 600 for these patients. And for median C-peptide for MODY group is 275. But there's overlap between the 3 groups. And then as for the age at diagnosis was an important determinant of the likelihood of reclassification. So anyone age above 30 had a more chance of being reclassified. As you can see, the ones who are below 18 years old were mainly type 1 diabetic, despite the entire investigation process. But between 18 to 30, there are a few patients that were reclassified as type 2 and MODY, and the same for patients that were above 30. They had higher chance of being in the type 2 diabetes group. For the monogenic diabetes reclassification, 14 individuals were reclassified as monogenic diabetes. 3 individuals had a pathogenic mutation plus 1 or more detectable antibodies. So patient 1 was thought to have monogenic diabetes alone with a false positive antibody, as implied by the antibody titer and type 1 genetic risk scoring. The other 2 participants considered to have a combination of type 1 diabetes as well as MODY. And like I said, the median C-peptide for MODY group was 275. 44 individuals were reclassified as type 2 diabetes. Of these, 14 patients had a C-peptide above 900, 8 patients had a C-peptide between 600 to 900, and 22 patients had a C-peptide between 200 and 599. Median C-peptide for type 2 diabetic group was 605 picomoles per liter. 7 of these patients actually presented with diabetic ketoacidosis, and 4 presented with ketonuria, but not all were all but 2 were Caucasian. 11 of these patients who were reclassified had a BMI less than 25 at diagnosis. Of these, 3 of them had a C-peptide over 900, and 2 of them had a C-peptide between 600 to 900. Across the whole cohort, reclassification occurred in 3 patients who were aged less than 18, compared with 16 patients who were aged between 18 to 30, and 39 patients aged above 30 years old. So it goes back to the slide that says that age at diagnosis was an important determinant of the likelihood of reclassification. In the first 2 age group, that is below 18 and between 18 to 30, there were similar proportions of individuals reclassified to monogenic diabetes as well as type 2 diabetes. Whereas if you're above 30 years of diagnosis, type 2 diabetes was the predominant reclassification. There were significant differences in age at diagnosis, duration of diabetes, and BMI between these with a final diagnosis of type 1, type 2 diabetes, and monogenic diabetes. Age at diagnosis was lowest in those with monogenic diabetes and highest in those with type 2 diabetes. Duration of diabetes was longest in those with monogenic diabetes and shortest with those with type 1 diabetes. BMI was highest with type in those with type 2 diabetes, and HbA1c was not significantly different between all the groups. So impact of reclassification on diabetes treatment. Insulin was discontinued in 11 individuals that were reclassified as type 2 diabetes, and insulin withdrawal was more successful in individuals with C-peptide above 900. 16 individuals had improved glycemic control following addition of co-therapies to their insulin regime. And monogenic diabetes, of the 7 individuals with sulfonylurea sensitive monogenic diabetes, 2 were able to discontinue insulin completely following commencement of glycoside. So, discussion. The clinical criteria traditionally used to determine the cause of diabetes are imperfect. This study measured random serum C-peptides in individuals with a clinician diagnosis of type 1 diabetes of more than 3 years duration. 13% retained substantial endogenous insulin production, and 6.8% had been misclassified. The majority of reclassifications were to type 2 diabetes, which is 5.1%, while 1.6% of the cohort had monogenic diabetes. And reclassification of diabetes then permitted the commencement of alternative anti-diabetic therapies. Overall, 13 individuals, which is 1.5%, discontinued insulin, and this was most likely in individuals with type 2 diabetes with C-peptide over 900. And 16 other individuals saw improvement in HbA1c after addition of co-therapies. While the proportion of individuals stopping insulin may appear low, there are approximately 400,000 people living with diabetes in the United Kingdom and the extrapolation of this data would imply that about approximately 6,400 people could be managed with therapies other than insulin. Also, insulin, although an acceptable therapy for type 2 diabetes, but newer agents reduce weight as well as cardiovascular risk and reduce risk of hypoglycemia, need for glucose monitoring, and restrictions around driving as well as employment. The total cost of the C-peptide testing program was estimated at £23,000 or approximately £27 per individual tested. So the study demonstrated that more than one cause of diabetes can coexist, such as type 1 diabetes and monogenic diabetes. However, it is unlikely to be clinically beneficial or cost-effective to test individuals with strongly positive antibodies for monogenic diabetes. The program also affirmed that DKA can occur in Caucasians with type 2 diabetes, and that endogenous insulin production can be maintained for many years in some people with type 1 diabetes. Retained endogenous insulin production in people with type 1 diabetes is associated with reduced variability in glucose and fewer lower glucose events. So the strength of the study is that it's easy, cost-effective method. It's done in outpatient settings. The limitation of the study is that it's one center, it's largely Caucasian population with no ethnic diversity. Antibody testing was carried out in some individuals many years after diagnosis. Antibody titers can fall with duration for type 1 diabetic. Therefore, some individuals with negative antibodies could have had type 1 diabetes. Detailed attempts at determining the etiology of diabetes could be considered unnecessary, as ultimately it may be the C-peptide level that determines the optimum therapy for the individual. However, the C-peptide trajectory may be different in different forms of diabetes. Example, an exponential decline in people with type 1 diabetes for approximately 7 years after diagnosis before stabilization. And there are benefits in establishing a diagnosis of monogenic diabetes beyond glycemic control. So in summary, routine C-peptide testing resulted in reclassification in 6.8% of individuals with a clinician diagnosis of type 1 diabetes. 3.4% of the cohort stopped insulin or have improved control with co-therapies. Overall, C-peptide testing was very cost-effective intervention and should be strongly considered in individuals with type 1 diabetes of more than 3 years duration. Currently, the NICE guidance does not recommend testing for C-peptide or islet cell antibody. And if this study were replicated in other centers, it may warrant a change in the NICE guidance. As a consequence of this paper, NHS Scotland has funded a national program of C-peptide testing and associated follow-up investigations for people with type 1 diabetes.
Wow, that's interesting. Any thoughts? The type 1 diabetes people?
Interesting. That were reclassified. I wonder if you did it here or if you showed.
It will be interesting because we have a much more diverse population. Yeah. It might be higher, there might be more type 2s, maybe.
Especially the one that came with PKA, but we normally do follow them up and see.
Yes.
Repeat C-peptide.
Do we do C-peptides? I just know that.
We do quite a few, not routinely, not in the same way that they did in Edinburgh, but we do a reasonable number.
Okay.
I mean, the problem is that you get lots of indeterminate ones.
Yeah, and 200.
Yeah, and then the question is, what do you do?
And what does it matter much about when you're doing it? Just random. I mean, intuitively.
You want the high glucose.
They said just random C-peptide as long and with checking blood sugars as long as the blood sugar is above 4.
But what I'm saying is, obviously, it might be quite different if the blood sugar is 4.5 compared to.
Yeah.
We've always said 8.
12.
Yeah, we've always said above 8 makes us feel confident that beta cells are being stimulated.
Yes, and the point is, depending when one's clinic is, when you might capture more 8s than 4s.
Yes, after lunch.
After lunch is fantastic. We do sometimes send people out to go and have a Mars bar before their bloods.
Okay, so you're only C-peptides in the clinic. See, these guys were not doing it at all.
Is the cutoff, are you using the same, I mean, what's your feel of the numbers? Because I don't actually have a feel. I've got a feel of a few hundred.
So this is a very white European Scottish population.
Yes.
And 200 is interesting because 200 has been the cutoff for type 1 diabetes since DCCT. So what's that? 1987.
Yeah.
So 200 is a reasonably confident floor for insulin deficiency.
Yeah.
900, I mean 600 and 900 are pretty arbitrary. 600, it's interesting that 600 comes out because a long time ago there was a 6-minute glucagon test that you used to do. So give people 1 milligram of glucagon IV, try to avoid the projectile vomiting and catch their C-peptide 6 minutes later. And 600 is the cutoff to exclude type 1 diabetes from that test.
Yeah.
So that's quite interesting that 600 seems to persist, again, in white European populations. But 900 is pretty arbitrary, really. And we've seen people who are raging the antibody positive diagnosis with C-peptides of 1200 and 1500. Okay. They've got type 1 diabetes, but they've got superadded insulin resistance and they're presenting earlier. Yeah. And they have very high C-peptides.
That's why they were saying wait 3 years.
Yeah, exactly. So 3 years is so this comes back to the thing that we always say, which is that time is the best diagnostic test.
Yeah.
They slightly sell themselves short in this because they're a bit obsessed with C-peptide, but actually what they've got is a stratified diagnostic algorithm that includes C-peptide, immunology, and genetics. And I think that message got a bit lost in the paper, and it's important to follow it all the way through because we do get lots of people who are in the middle somewhere and we don't know what to do with them. I am less convinced by the genetic risk score and what that adds here. Kavita, you said that the GRS differentiates type 1 NODI and type 2. It doesn't. It's good at differentiating type 1 and NODI. It's very poor at differentiating type 2 and NODI. Okay. So, and even the type 1 and NODI limits are very overlapping. I'm not sure what it adds. If someone's
what is the genetic risk score? Sorry.
So it's a series of SNPs that essentially give you an overall genetic risk of type 1 diabetes. What it adds to family history and the fact that your mum's got pernicious anemia and sister's got autoimmune hypothyroidism, which is what we much more commonly are able to do. What it adds to that, and a good careful history, is a little bit unclear to me. And we don't routinely use a genetic risk score. It's a very good research tool for large populations, but it's not applicable to individuals in the way that they have used it here. I don't think many people that went down that, where you've got a GAD at 17, what do we do with you? I don't think many of those people got much useful information out of that.
May I answer another question? Do you think you do see I know that antibodies wane, but do you think you see antibodies sometimes in type 2?
Yeah, absolutely. 3 to 4% of the population are one antibody positive.
I seem to remember it being quite common in the Afro-Caribbean population, but maybe it's all.
Ethnic variation is very poorly described, but there is a background positivity for Islet-specific autoantibodies, just as there's a background positivity of TPO, ANA, and all the other antibodies. Whether they are progressive and significant pathophysiology is unclear, and that's why if you just have one and you've got reasonable C-peptide, they send you down this further down the algorithm because it's not diagnostic. And obviously, if you've got GADs of over 250 at diagnosis and you present with ketosis and weight loss, it's very easy, isn't it? But the problem is, as Kavita said, they were doing the antibodies after decades in some of the people. I mean, we still see GADs after decades. GADs persist for years. IA2s tend to wane in months. Zinc transporters, if they're present, can wane in weeks after diagnosis. So yeah, it's a bit muddy. I think this sort of structure is better if you do it at 3 years, so that everyone has the same data. But they're doing it pan Scotland, and Scotland, of course, has a fantastic national database for diabetes. So in 2 or 3 years, we will have a pan Scotland database for this that will be super interesting and will hopefully include lots more ethnic and geographical variants. I think the age thing's really important, though. I think that's what it's saying there, really, is don't bother with kids. You're much more likely to reclassify adults, do it in the 18s and overs. Yeah. Yeah.
And actually, presumably, the most beneficial group are the emojis that then go on the tablet. But it was also saying how the control got better in some of the other groups, presumably because they're adding, they may stay on this week.
Adding in the
metformin or the flozin.
Yeah, no, absolutely.
Yeah.
So we will not see this benefit because we are doing some C-peptides anyway. Because they call, well, that's quite a lot, 6%, but we've already taken some of them off by doing C-peptide.
We had a flurry a few years ago of doing quite a lot of C-peptides and autoantibodies, and we classified a reasonable number of our genetic. I'm sure there are still more to reclassify, but we hopefully caught a few.
You probably did it at the same time, but I've been doing it.
We've been doing it, started doing C-peptides 7 or 8 years ago. Okay.
Yeah.
Sporadically. What we probably should do is do it more systematically and have a flag to do it after 3 years after diagnosis, or as close to
it. Yeah, just to capture, because we forget. That's the honest thing, that we get infused and then capture a cohort and rescreen those, but then
yeah, absolutely.
Very good. Thank you very much, Kavita.